Our first speaker will be Dr. Ed Weisbart, who will present an overview of the direct contract entities, and he will speak with a PowerPoint. And just to introduce Dr. Weisbart, he is a national board member of Physicians for a National Health Program, and he chairs the Missouri chapter. After practicing family medicine for over 20 years at Rush Medical Center in Chicago, he moved to St. Louis in 2003 to serve as Chief Medical Officer of Express Scripts until retiring in 2010. Thank you, Dr. Weisbart, for joining us tonight, and go ahead with your presentation here.
Well, thank you, Dr. Rogers. So here we go again, right? We're here tonight because of a new scheme to privatize Medicare, to transform it from a public good into just another channel for corporate profits, where a dollar spent on healthcare is a dollar diverted away from the bottom line of Wall Street investors and others. I admit right now that direct contracting story is complicated, and that's frankly one of the differences between DCE and Medicare for All. Remember, nobody is asking us to make healthcare more complicated unless they want to hide something in the complexity. So I think the story actually starts, frankly, before direct contracting. It starts, we've been in a generational struggle. There we go. We've been in frankly, a generational struggle between viewing healthcare as a public good and viewing it as a corporate investment opportunity. Direct contracting is the newest attack on Medicare, but we should start tonight's story with Medicare Advantage. Until direct contracting came up, Medicare Advantage has frankly been the most obvious and successful push to privatize, to end traditional Medicare and privatize it. So just to unpack Medicare Advantage for just a moment, here's traditional Medicare, right? We pay our taxes and we get, and the federal government then gives us Medicare, and Medicare negotiates directly, essentially, with the physicians and hospitals. And that's traditional Medicare with maybe some Medicare managed administrators. Medicare Advantage is quite different from that. Medicare Advantage is introduces a risk-bearing intermediary between Medicare and physicians. So it's the Medicare Advantage folks who get essentially their funds directly from Medicare, and then they contract with physicians and hospitals. So we've frankly had most of our advocacy eyes on Medicare Advantage because of our concerns, and we've seen Medicare Advantage growing over the last few years, and we've not been as focused on this new attack on traditional Medicare. But traditional Medicare is frankly larger than Medicare Advantage has ever been. So that's sort of the thrust of the direct contracting entities. It's to create new risk-bearing intermediaries in between Medicare and physicians and hospitals. And that creates conflicts of interest that we're going to point out to you. Direct contracting is a concept that was begun under the Trump administration, and it's even now still in the pilot project phase within Medicare. So if we did want to intervene, it's important to do it quickly while it's a pilot. It's a pilot project introduced by the Center for Medicare and Medicaid Innovation. This is a center created under Section 3021 of the Affordable Care Act to overcome what was recognized as a problem of anti-reform inertia. So the Affordable Care Act created the Centers for Medicare Innovation and gave it the ability to do a pilot project that they can then widely apply across Medicare if Health and Human Services believes that their pilot project is favorable. In other words, it reduces spending without decreasing cost or quality, or it improves quality without increasing spending. One of those two things, while not denying or limiting coverage or provision of benefits. So that's the charter of the Center for Medicare Innovation. The key point here is that if HHS believes that one of their pilot projects meets these criteria, it can roll the project out across Medicare without going back to Congress for additional approval. They have that approval. And some of their innovations are frankly better, and some are than some others. So tonight we're talking about direct contracting, and this comes in a few flavors, a few different models. I'm just going to focus a bit on two of these, the most dominant ones, I think. The first is the one that's gotten a lot of attention, which is called the geographic direct contracting model, and that's or the GEO model. This would take all traditional members, Medicare members, in a specific region, a metropolitan service area or whatever, and align them to that region's. Everybody in there would be aligned, is what they call it, to that region's direct contracting entity. This particular program, which is the one that I think most people are familiar with, is actually on pause by the Medicare Innovation Center, and it's not moving forward. There's no indication at the moment that it's going to be moving forward. There's no word about that. But the reason it's worth bearing in mind is because it's an example of an ability of the Medicare Innovation Center to literally move or align everybody from traditional Medicare into one of these corporate focused entities. Not active today, no word that it's about to become active, but it could be reactivated really at any time or something like that. But that's not on the table today, and hopefully it wouldn't be. What is more active today is what's called the global and professional direct contracting model, or the GPDC or GLOPRO, in case we haven't had enough acronyms lately. So in this model, your medical claims data as a patient in traditional Medicare would be used to identify who the system believes to be your primary care physician, and then automatically align you, without asking you, into that primary care physician's direct contracting entity. This program is not on pause today. There are 53 pilots going on. And then in addition to being auto-aligned, if you wanted to, you could voluntarily sign up for your primary care physician's direct contracting entity. So these DCEs have two main revenue streams, either capitation or financial risk. We'll unpack them both for a moment. Capitation can be either limited to just having the DCE capitated for primary care, or actually bear a capitation for everything in your healthcare dollar. So primary care or total care. And then the DCE pays for the healthcare from their capitation dollars, pays for the care that's within the DCE's network, only within the DCE's network via the DCE's own contracts. However, Medicare patients are completely at freedom, despite being in a DCE, are at complete freedom, this kind of DCE, are at complete freedom to go outside of that DCE. And if they do, then there's somewhere the DCA doesn't have a contract with, and so Medicare directly pays for that care, and then in some process reconciles that expense back with the direct contracting entity. So capitation is one piece of revenue for the DCEs. The second piece is financial risk and how will they manage it. So the DCE can bear risk for the costs that are either greater or less than the benchmark for their population that's been set by Medicare. And this comes in two forms. They can do the global risk, which is bearing 100% risk by the DCE, or just the professional risk, which is bearing only half of the risk with Medicare. So if they are less expensive than the benchmark, they can keep either 100 or 50% of that savings, and if they're more expensive, they bear either 150 or 100 or 50% of the overage. So the words global or professional refer to how much of the risk they share, not what they're responsible for. Both global and professional models are responsible for essentially all the services that we think of today as being part of Medicare's Part A and B. So a little funny bit of naming there. So DCEs, in my mind, are going to be under significant pressure to upcode to get larger capitations. This means that the DCE will start by engaging primary care physicians, putting them into their networks. And then once they've done that, then Medicare capitates the direct contracting entity for the patients that are within that primary care physician's practice, either in whatever way they chose to, as I mentioned. And then the DCE is under pressure, frankly, to maximize that capitation by this system called upcoding. This is my assessment of that. Now, we don't have any information on whether or not DCEs are upcoding much at this point because they're too new. So I can't unpack upcoding as a thing that's being done by DCEs today, but the exact same pressures to upcode are long established within Medicare Advantage, so Medicare Advantage plans can get higher payments. So let me explain what upcoding is and how that works. It's all based on coding the things the physician enters when we see the patient and submit a bill. We put in diagnostic codes. We say the person has hypertension or diabetes or whatever. We put in diagnosis codes, And then these codes drive a risk score that's calculated by Medicare. And the risk score is then used to determine Medicare Advantage reimbursements and eventually DCE type reimbursements. So let me unpack this for you. Here's the way the risk score would be calculated for a healthy, find one of those, a healthy 76-year-old woman, and the hierarchical condition categories, or the HCC, is essentially the risk codes. So this woman would have no extra codes, and her risk score would be 0.45, and Medicare would pay the Medicare Advantage plan in 2019, when this was developed, $4,000 per year to take care of her. Now, if that person is sicker, it's appropriate for the Medicare Advantage plan to be paid more for a sicker person, you could say. And so here's somebody, same person, but adding in some diagnoses. And if you put together those diagnostic codes, the risk score goes up to 1.03, and then that plan gets significantly more. So a plan that ignored adequate coding would be losing a lot of money. So that's sort of straightforward risk coding, but there's a big opportunity to maximize the coding. And to get these codes, there's a whole industry around doing this. So for example, if I were to see somebody and code them as having obesity, that's worth nothing to the Medicare Advantage plan. But if I code them as having morbid obesity, that's worth a significant bump up in their risk coding. At the end of the day, these comparable codes more than triple what Medicare would be paying that Medicare Advantage plan. So there's an industry around getting these codes so that the Medicare Advantage plan, and I propose probably the DCEs, would be able to do the same kind of game. And Medicare Advantage has gotten really good at this. So they've been able to upcode dramatically since they started looking closely at it. And those changes have nothing to do with change in real risk. It's a big opportunity. And in fact, it's in the order of hundreds of billions of dollars for this 7-year period. The same kind of strategy wouldn't have the same kind of impact under DCEs, but still a substantial impact. The rules are a bit different, so they probably wouldn't have quite the same dollar amount, but still significant. And these are the kinds of numbers that get attention on Wall Street, which is where most DCEs are owned. So fewer than half of DCEs are owned by provider groups like ACOs and physician groups and such, but most are frankly owned by investors, either publicly traded or publicly backed. And only a handful are owned by insurance companies at this point. There's 53, 6 are owned by insurance companies, but those 6 are far and away the largest of this group. So the problem that I see with the direct contracting model is that it is a huge step forward, could potentially complete the full privatization of our public precious good called Medicare. It violates the spirit of a public health program, like which Medicare is, by driving larger corporate profits as a priority over improving our health, which Medicare is remarkably successful at. It corrodes the value, frankly, of a public health plan by creating these opportunities for profiteering. And if we want to rally behind Medicare for all, let DCE take over Medicare, the traditional Medicare, and I'm not sure what it is that we would be rallying behind. So it's a big threat to our movement.